Hello, good afternoon. So, very nice. As I say, I've come here for the last 3 years, I think, and talked about diabetes and tuberculosis, and we've got a little bit more of an understanding about how these two diseases interact. Before I start, it's always very nice to get to know people. So, can I just say, Amy, where are you from?
From South Africa.
South Africa, fantastic. And Nomaswazi? Is that how you pronounce it? From South Africa, great, yeah. Zishen? Beijing, okay, fantastic. Sumitra? From India, okay. Nutsa?
From Georgia.
From Georgia, okay, very good. Paidamoyo, is that right?
No, that's right, from Zimbabwe.
Zimbabwe, excellent. Mukesh?
Yeah, I'm from India.
India, right. Sheila?
From Philippines.
Philippines. Zheng?
From China.
From China. And Carol?
From Uganda.
From Uganda, right. Okay, Shui?
From
Myanmar, excellent. Robert? Zimbabwe. Dawei? China. And everybody else is here. That's right. Well, anyway, very nice. Thank you. Thank you for coming. I hope you're enjoying the lovely weather in Barcelona. This is winter in Barcelona, you know? Unbelievable. I came with winter clothes, and I think I should have brought summer clothes and swimming trunks to go and swim in the Mediterranean. So, very good. So, what I want to do, we'll go through this slowly, and please feel free to ask me any questions if you don't understand as we go through, and then we'll have also a discussion at the end. But I want to give you some background epidemiology. What that means is some facts about diabetes and tuberculosis in the world, and in the two countries most heavily affected by these two diseases, which is China and also India. Okay. I'd like to talk to you secondly about what's called the Collaborative Framework for Care. So this was a document, a policy document that the WHO and the Union put together and launched in 2011 to say this is how we ought to try and deal with a patient who has both diseases. Yeah. Thirdly, I want to just look at 3 challenges that we have for care and take you through that, and finally wrap up with some concluding messages. Okay? So as I say, please interrupt me as I go along if you don't understand. Let's just go back to some basics. Diabetes. Diabetes mellitus. There's actually, interestingly, there's 2 types of diabetes. There's diabetes mellitus, which means, if you like, diabetes that is sweet, sugary. And there's another diabetes called diabetes insipidus, which is watery diabetes. And diabetes insipidus is due to a tumor in the brain. All right? It's completely different to this. Yeah? So diabetes mellitus is essentially sweet diabetes, if you like. It's been known about for a long time. If you look at European classical history, and you look at writings from the Greeks and writings from the Romans, these were 2 great civilizations that, you know, lived before Christ, so 3,000 years ago. They talk of a disease where people basically got thirsty. They passed a lot of urine, and the urine that they passed was sweet, yeah, sweet tasting. Now, I don't know why you want to taste urine, but anyway, it's written like that in the classical literature. And interestingly, sometimes when especially when men urinate, they sort of dribble a bit on their shoes, and you can see sugar deposits on the shoes. And this was picked up by basically in the classical literature. So it's very, very interesting. It's been around for 3,000 years. There are 3 main types of diabetes. There's type 1, type 2, and what we call gestational. Now, just very quickly, type 1 diabetes is when the cells that produce insulin in the pancreas, and the pancreas is here in our abdomens, those cells get affected by an autoimmune response. They stop working. So you don't produce insulin, and your blood sugar rises, and it's a serious problem. And it normally affects young people in their teenage years, all right? And really, type 1 diabetes, before insulin became available, you died. 100%. You died of diabetes, yeah? Type 2 diabetes, which is what, when we talk about this great epidemic of diabetes in the world, it's due to type 2. So the pancreas and the cells produce insulin, all right? But the insulin does not work to basically ensure that sugar goes from your blood into the cells. You with me? So you get too much sugar in the blood. So it's not because of a lack of insulin, it's because the insulin is not working properly, all right? And then finally, gestational diabetes. So for the ladies here, this means that if you get pregnant, you can get diabetes when you're pregnant, all right? So, oh, horrible, you know, worry, worry, worry. As soon as the pregnancy is finished, the diabetes goes away, all right? So it's related to pregnancy. So it's called gestational diabetes. But interestingly, if you're a young woman and you have gestational diabetes, you are at risk of getting type 2 diabetes later on in life. So it's a risk factor, okay? Now, how do we make the diagnosis of diabetes? Essentially, it's by some form of measurement of blood sugar, all right? So we have to take a blood test and measure the amount of sugar in the blood. It's a little bit complicated, and normally, the two good ways, which is called what's called a fasting blood sugar. So Sumitra, I would ask you, say at 8 o'clock tonight to eat nothing, drink nothing, and tomorrow morning at 8 o'clock I take a blood test. That's called a fasting blood sugar, okay? And there's a cut-off level, I'll explain it, and if you're above that level, then I say, Sumitra, very sorry, you have diabetes, okay? That's one way. There's another way, which is a bit better, all right, where I could give you Nutsa, I'd give you what's called a 75-gram glucose drink. It's horrible. I've done this. It's horrible. I have to drink it down, yeah? And then 2 hours later, I measure the amount of glucose in your body. So if you have not got diabetes, your body handles that, and sugar comes into your bloodstream, but it gets into the cells, and the sugar level goes down in the blood. If you've got diabetes, that system doesn't work. All right, and so your sugar level stays high. And then finally, there's a way of measuring now glucose in the red blood cells. It's called glycated hemoglobin. It's a rather complicated name, glycated hemoglobin. But you need a special machine, and that's very good because the blood cells last for however long, 3 months, all right? So it gives you a picture of what's happened in the last 3 months to the blood sugar in your body. Whereas a fasting blood glucose just tells you at this moment in time, tomorrow morning, Sumitra, what your level is, all right? So anyway, it's some form of blood glucose, and treatment is diet, tablets, or insulin. And as far as we know, we can't cure diabetes, all right? So it's a problem for life. Is everyone happy in general about then what diabetes is? Any quick questions on diabetes? Yeah, you've got enough information, yeah? I think you're experts on tuberculosis now, are you? So, disease of antiquity, yeah? Do you know how long ago the first tuberculosis was discovered? It was in a skeleton. Do you know how long ago and where that was? Anybody? 5,000 years before Christ, they dug up a skeleton in Italy, Roman skeleton, and that Roman skeleton had TB. So it's been around for 7,000 years, yeah, in the human body, yeah. Obviously, sort of we have sort of epidemics, and in Europe, 200 years ago, it was a major killer. All right, and we had rates that were much higher than we have rates now in the world. 3 main types of disease, just to put this very simply in perspective. Tuberculosis affects the lungs, so it's called pulmonary tuberculosis, but it also affects other parts of the body. Yeah. So, any of you know where else in the body TB could affect? Spine. Very good.
Every part, kidney.
Yeah, TB, spine, kidney, brain, lymph nodes, round the heart, outside of a lung, sorry?
Bones.
Bones, yep. Gastrointestinal tract. So it's called, and we call that extrapulmonary tuberculosis. We have pulmonary TB, which is about 3/4 of all TB is pulmonary TB, and about 1/4 of TB is extrapulmonary TB. We also divide TB into bacteriologically confirmed and not confirmed. Now, what is that? What do I mean by that? It means that if I've got pulmonary TB and I'm coughing, and I cough up sputum, if you put it on a slide and you can see the germs, we call that bacteriologically confirmed. You're happy with that, yeah? Yeah? Have you been taught about that yesterday and today? Call it sputum smear positive pulmonary tuberculosis. You can be sputum negative, meaning I look on the slide, I can't find any germs, but I can grow the sputum in a special medium, yes, on a dish, and then after about 2 months, 3 months, that can grow up into, we can see TB germs as what we call colonies of growth, and we call that bacteriologically confirmed as well, okay? But sometimes, so Shui, you may have pulmonary TB and I get your sputum, I can't find any germs, I try and grow it, I don't grow anything, but I think on the x-ray, on your clinical appearance, I think you've got tuberculosis. So I would call you not bacteriologically confirmed, but I'm going to treat you. So you with me? That's a difference. And then finally, we have drug-sensitive and drug-resistant TB, and I think you probably, have you had talks on drug-resistant TB yet? Yeah. So you know all about drug-resistant TB, yeah? If you're going to get TB, do not get drug-resistant TB, all right? Because the treatment is horrible. It's 2 years. Get drug-sensitive TB, please. The diagnosis, we look for basically sputum for acid-fast bacilli. AFB stands for acid-fast bacilli. It's our scientific word for tuberculosis bacilli, and treatments for 6 months. Yeah, it's very interesting. We call it short-course chemotherapy. It's a bit odd, isn't it? Does short course for 6 months sound short course to you? No, that's right, Amy. It doesn't sound short course to me. But it's historical because when I first went to Africa in sort of the early 80s, we used to treat patients for 12 to 18 months. Yeah. Because we didn't quite have the drugs then. So short course was so if it's 6 months, it's shorter than 12 to 18 months. You with me? So that's why it became short course chemotherapy. So let's have a look at this. Now I've just updated this. When I sent Linda my presentation, it was before I had the global TB report. So I've updated this from my brain, and I hope it's correct. I'm sure it's correct because I sort of know the numbers. Let's look at diabetes. 383 million people living in the world with diabetes. That's quite a burden, yeah? People talk, let me put it into context, people talk about the great burden of HIV/AIDS in the world, and I think my great colleague Jane Carter spoke to you yesterday. 35 million people living in the world with HIV/AIDS. This is 10 times that, yeah? It's a big burden of disease. Every year, 10 million new people get diabetes. So in 2014, it'll be 393 million. The next year, it'll be 403 million, roughly, okay? And approximately 5 million people die every year as a result of complications of diabetes. Those complications are kidney disease, heart disease, largely, all right? Sometimes amputations that go wrong because diabetes can affect the blood vessels. You don't get good blood supply to your legs. They go gangrenous, right? So it's a nasty disease to have, yeah? If you have it, you need to be under somebody who's going to control it properly. On the right-hand side, you can see the burden of tuberculosis. I guess you know this in your sleep now, yeah? So basically 9 million new cases, which is a lot of people getting tuberculosis, and 1.5 million people dying. It still staggers me. For a disease that is infectious, you can diagnose it, you can treat it, you can cure it. Why have we got 1.5 million people dying? Well, it's because it's a disease of poverty, and you know, in poor countries we don't possess, if you like, the way of reaching people quickly to make the diagnosis and get them onto treatment. There's other reasons as well, but where do these diseases occur? Let's just look first of all at tuberculosis. So this just tells you that Southeast Asia, the Western Pacific, Africa are the big places, all right? And you can sum it up by saying that 95% of all tuberculosis in the world occurs in LIC. What do I mean by LIC? Anybody? Very good. Low-income countries or middle-income countries, okay? Now, I started getting into this work, in fact, about 5 or 6 years ago. I was amazed at actually the distribution of global diabetes, because it's similar. 19% in Southeast Asia, 36% in the Western Pacific, 4% in Africa. Not so much in Africa. But 80% of the diabetic burden in the world is in low and middle income countries. Now, some people say to me, okay, but maybe it's in the rich people living in low and middle income countries. Not so. It's in your urban poor people who have undergone a change in lifestyle, all right? So they don't take so much exercise, they buy cheap food, eat the wrong food, and as a result, get diabetes. And probably they are genetically predisposed to getting diabetes, yeah? So in India, for example, if you go back in time, probably one struggled in India, to get food. So your babies were born to learn how to cope with not sufficient food, all right? You then have a baby born, grow up, and you've got sufficient food but the wrong type of food. That baby then, if you like, is very susceptible to getting a disease like diabetes. Is that sort of clear, yeah? So there's definitely a genetic component here. Now, India and China, and I'm very sorry I don't have the 2013 data. I couldn't dig it out of my brain. It's somewhere in here. But it's to give you the picture. Now, India and China have, first of all, the 2 biggest TB burdens in the world, and they have the 2 biggest diabetes burdens in the world. Yeah? So let's look at India. And I think for 2013, it'll be roughly the same here. But 63 million people in India living with diabetes, 2.2 million people each year getting tuberculosis. Big burden, yeah? So Mukesh, if we can get a handle on TB in India, you know, we're going to make a big impact globally, yeah? China. So where are my friends from China, yeah? Yeah. So China, you are the diabetes capital of the world. Yeah, I think now you're almost at 100 million people with diabetes in China. Yeah, so very interesting. You've got a big problem. You haven't got so much tuberculosis. You've got 1 million TB cases a year. But in terms of Premier League, China, you're top of the diabetes Premier League table, and India, you are top of the TB Premier League table. Yeah. Now, very important. Let's look at tuberculosis first, because you've heard this. 9 million people last year with TB, of whom 3.3 million were missed. We don't know what happened to them. We don't know if they were treated, diagnosed in the private sector. They were not notified to national authorities, so we don't know. Look at diabetes. 383 million people with diabetes, half of whom have not been diagnosed and do not know they have the disease. Yeah? Now that's a problem, because the diabetes will continue, high blood sugar levels, they will have their kidneys go wrong, they will have their nerves go wrong, they will have their blood vessels sort of thicken up, yeah? They will get heart disease, and they will get what we call peripheral arterial disease. The blood supply to the legs won't work. They'll get into trouble. So the longer they are undiagnosed, untreated, the more serious it is, because they will develop complications. There's another big complication with diabetes, which is eyes. Okay? Diabetes affects the back of the eyes. Okay? It's called a retinopathy. So if you don't treat it, don't get a handle with it, you go blind. All right? So it's a big problem, this. And I think it's important to note. So half the people in the world with diabetes are undiagnosed. Now, Let's look at tuberculosis. I think, were you at the symposium, the Stop TB? You probably weren't at the Stop TB symposium. So let me just summarize with tuberculosis. Tuberculosis is on the decline, or very, very slow decline, actually, yeah? For the last 10 years, it's been going down, but at 2% per year. And actually, if I look carefully at the data from WHO, that decline is slowing down. The last 3 years, it's 1.5% per year. The last year, between 2012 and 2013, it's 0.6% decline. It's slowing down. I could almost predict to you that next year, that decline will stop. And then what's going to happen? Are we going to go up? Are we going to stay the same? I'm not sure. Yeah? This is why diabetes and TB is important, and I'll come to it. So TB is going down, not so with diabetes. These are the predictions, that in 17 years' time, this number, 383 million, will rise to 552 million. And by 2035, to go in line with TB targets, we will have 600 million people on the planet with diabetes if we don't do something about it. So diabetes is going up, TB is going down. Okay? If the two epidemics were in completely different people and didn't interlink, it wouldn't matter. You with me? Yeah? If the people who got diabetes were not the people who got tuberculosis, this wouldn't matter to TB. Unfortunately, there's an interlink. Yeah? And I'll come to that. So, let's just revise a little bit about risk factors for TB. So, the tubercle bacillus is a bacteria, okay? And it's reckoned about 2 billion people in the world carry this bacteria in their bodies. I definitely know I carry the bacteria in my body, right? Because you can do a skin test, and my skin test is very positive. I would guess some of you here carry tubercle bacilli in your bodies. But we don't know unless I do a skin test on you. And I'm not going to do a skin test on you, so it's all right. Now, of those 2 billion people who carry TB germs in their bodies, they have a lifetime risk of getting active tuberculosis that is 5% to 15%. It's not that high. It means about 90% of people who carry the germs are going to live and die without getting tuberculosis. Everyone happy about that, yeah? People often ask me, where do these germs live? They probably live in the lungs. That's where they live, probably, yeah? And when something happens, then the germs start to multiply, and then when they're at sufficient numbers, they cause disease, okay? So, 5 to 15%. Now that risk of 5 to 15% is increased in certain situations. So let me just go through that. If you have a little baby and your baby of 1 year old gets exposed and gets infected with tuberculosis, that baby has much more than a 5% risk of getting TB. The risk is 20%. Babies are at high risk. As we get older, our immunity goes down. We become more at risk of getting tuberculosis. HIV/AIDS, you heard about this yesterday, yeah? Very high risk, particularly if you have very low immunity. Other causes of immune suppression, steroid. Everyone know what I mean by steroids, yeah? Do you know steroids? Steroid drugs, yeah? If you have asthma, sometimes you take steroids to control, yeah? If you've got inflammatory disease, doctors often give people steroids. It's a good drug. It reduces the inflammation, but it predisposes you to TB, so beware. Silicosis. Silicosis is a disease of miners. If you go and work in the mines, you get these particles in the lung, and if you've got silicosis, you're at risk of getting tuberculosis. Malnutrition, smoke, alcohol, boom, diabetes. So let's have a look at this link. Very interesting. It was recognized way back 2,500 years ago in the writings, where people wrote to say, here we have somebody who passes lots of urine, whose urine tastes sweet, and those people are getting a disease where they waste away and they cough up blood. probably tuberculosis, although you couldn't diagnose tuberculosis 2,500 years ago. So it was recognized in the literature 2,500 years ago. It's only in the last 6 years that really we've woken up about this link. So there's been quite a lot of people writing about this in the last 30 years, you know, studies from India, studies from Georgia, studies from China, yeah, saying, oh, here's some patients, and these diabetic patients are at risk of TB, but no one had really systematically looked at it. Well, these two people here, Catherine Stevenson, who worked in WHO, and Christy Gion and Megan Murray, who worked in America, did two very nice, what we call systematic reviews, where they said, looking at the world literature, if you have diabetes, your risk of TB is increased by 2 or 3 times. Now that's substantial, all right? Let me just ask you, how much does HIV/AIDS increase your risk of TB? Yeah, about 30 times, not 30%, 30 times. So if I'm HIV, you're not, I have a 30 times increased chance of getting TB. So similarly with diabetes, if you're normal, I'm diabetic, I have a 3 times increased chance. It doesn't sound huge, but if you look at the numbers we're dealing with, this could be important. Okay. So the first thing to ask, does this make sense that people with diabetes are at increased risk of TB? And the answer is yes, it does make sense. First of all, you can that little mouse on your right is a normal mouse, and that fat mouse next to it is a diabetic mouse. Sorry, people do work on animals, all right? So, so the mice are a good model to study diabetes. So, if you look at the fat mouse and you look at its markers of immunity, they're way down. Okay, if you give both mice some TB germs, the mouse on the right does okay, the mouse on the left can't control the TB. The TB germs multiply and you get lots and lots of TB. So diabetes does something to your immune system in mice. We also know, though, that patients with diabetes have impaired immunity and poor lung defenses against TB. We don't, so I'm going to put it in a nutshell for you, we don't really understand the mechanisms, okay? And there's people who need to do research into this to say why exactly are diabetics at risk of tuberculosis. But there's evidence to show that their immunity is weakened, especially their immunity to TB. So, there's a linkage. Now, these were estimates published this year for WHO in 2012. Let me just take you through this. The world population attributable fraction. So what this means is that 8% of adult tuberculosis in the world, all right, is due to diabetes. You with me? And they might say 10% is due to smoking. All right, and maybe 15% is due to HIV/AIDS. You with me? Yeah. Don't look at this middle column. Look at the column on the right. So these are WHO estimates. They estimate that just over 1 million people in the world have both TB and diabetes. Can you remember the numbers for HIV and TB from yesterday? It's awful to bombard you. You end up at a conference like this, lots of numbers swimming around in one's mind, and one can't remember the numbers at all. But can you remember?
Dr. Harris, I'm sorry, I
Yeah.
have a question about what you said earlier. Would you put that 8.3% into a sentence?
Yeah. Okay. So what it means is that supposing in this room we've all got tuberculosis, we'd say that 8% is due to diabetes, meaning somebody in this room might have diabetes. You with me? It's the contribution that diabetes makes to the burden of tuberculosis. You with me there? Yeah?
8.3% of diabetics?
No, it's not quite like that. It's called the population attributable fraction. It's saying that Here we have the global burden of tuberculosis. What's driving this, all right? So it's saying that 8% is driven by diabetes, 10% is driven by people who smoke too much, 15% is driven by people with HIV/AIDS. You with me? Yeah? But the important column really is the one right over here. So just over 1 million people have diabetes and TB. In the world, in fact, it's 1.1 million have HIV and TB. So it's the same sort of burden. You with me? Yeah? And then if you look at the various regions of the world, we have Southeast Asia, which houses India, all right? So 423,000 people in India with diabetes and tuberculosis. Western Pacific, my friends from China, that houses China, all right? 238,000 people in China, all right? Well, sorry, in the Western region. You with me? And then you go down to Africa, Europe, the Eastern Mediterranean, the Americas. I think the important thing here is just to highlight that it's 1 million people estimated to have diabetes and TB, and the two big regions are Southeast Asia and the Western Pacific. Everyone happy with that? Yeah? Let's just look at countries. So again, let's focus on that left-hand column. Look at India. They reckon in India about 300,000 people with diabetes and TB in 2012, all right? And in China, about 156,000. So if you look at that burden of diabetes and TB, which is 1 million, if I wanted to be fairly sort of simple in my mind, I'd say nearly half of that burden occurs in India and in China. Yeah? And then the rest is spread throughout the world. So is everyone clear about that? Yeah? And that's going to grow. That will get bigger and bigger. Yeah? That's the problem. So does anyone want to ask me any questions about epidemiology? That's all I wanted to say. You okay about that? About the burden of disease? Yeah? Happy? Africa, not yet a problem, but you know what they predict? They say in the next 10 years, Africa is going to be the biggest region in terms of increased prevalence of diabetes. You know, I spent 22 years living in Malawi, and towards my last 3 years, guess who comes in? McDonald's, Kentucky Fried Chicken. Oh, it's great, you know. Quick food, very tasty, yep. And in the urban cities, people queue up, you know. And of course, with your Kentucky Fried Chicken, you get Coca-Cola, yeah. Tomato ketchup, mayonnaise, all the sort of things that really not very good for you, okay. So Africa is gonna, they say, they're gonna predict it's gonna take off, yeah? Now, that's the bad news. What are we gonna do about all of this, okay? Now let me just give you a bit of history. In 2009, November, we had what's called an expert meeting that we convened in Paris. And the World Health Organization, ourselves at the Union, WDF stands for the World Diabetes Foundation, yeah? And IDF stands for the International Diabetes Federation. So they said, we must get together and think, is this a serious problem? Do we need to have international guidelines? So we had a very, very good meeting, and we decided on this. We decided that there definitely is an interaction between diabetes and TB. Yeah? We said we need to give the world some guidance about what to do. The problem is that when you produce guidance from WHO, it's what's called evidence-based. You need evidence, data, to underpin that guidance. And there really wasn't fantastic data. It was very weak. So they said we cannot issue guidelines, but we can issue what's called a provisional framework. Everyone happy with that? It's like the structure of a house, all right? And we launched this in 2011, and the idea is that next year we review this framework and see whether we can tighten up a little bit on guidelines, okay? So this is what the framework looks like. It's a nice document. I'm sorry I haven't got copies here, actually. Didn't bring any. I've run out, actually, to be honest. It's about a 38-page document, quite succinct, explains about the evidence and explains what should be done. And these are the recommendations. Now, I'm not going to labor this, but essentially it says, under A, we need to bring the two programs together. You probably heard this yesterday between HIV and tuberculosis. They have to get together to decide what to do. The same here, the diabetes world, the TB world have got to come together, all right? Now, under B, let's look at this. We need to detect and manage tuberculosis in patients with diabetes. B1, we want to intensify the detection of TB among people with diabetes. We want to make sure we've got good TB infection control in healthcare settings where diabetes patients come together. So if I'm a diabetic, I will come to a hospital, to a diabetic clinic, and I will sit in a waiting room with 100 other people waiting to be seen. Now, if a few people have TB, as you're sitting in this room with no windows, no ventilation, very good to transmit tuberculosis, okay? So we need to think about infection control. And if we identify diabetic patients with TB, we need to ensure they get referred for TB treatment, yeah? One of the key messages I heard this morning from Mario Reviglione's talk from WHO was last year they identified 136,000 people with multi-drug resistant TB and 90,000 people got treated. Wow, what happened to the 46,000 who didn't get treated? Yeah? So it's not good enough to just diagnose. We must diagnose and make sure people get to treatment, okay? And then finally, C, C1 and C2 is the other way round. You with me? We need to screen TB patients for diabetes and make sure if we find it, that we give them high quality diabetes management. Is everyone happy about that? Very simple. It's what's called bidirectional screening. Now, very quickly, this is the last part of my talk, look at the 3 challenges for care. So let's look at this bidirectional screening. And I want to give you some work, some data from work we've done, Dawei in your country, China, and India, also in India, yeah, because we did some quite nice work there. So 2 points. Screening TB patients for diabetes. We're going to have to do some form of blood test, yeah? Zheng, I can't, if you're a TB patient, I can't look at you and say, Zheng, you've got diabetes. No way I can diagnose it clinically. I'm going to have to do a blood test on you. So it slightly complicates it, all right? In screening diabetic patients for active TB, one of the problems we have is that TB in diabetic patients can present a little bit differently. Not quite the sort of, what I would say, the classic features, all right? So it's easy to miss, yeah? And that's a problem. So we just need to remember that. So let me tell you about this work, and I just want to describe, it was, I think it was a very, very good model for doing work in a new area. So let me tell you how it went. So it worked the same in both China and in India. So WHO, the Union, World Diabetes Foundation, for example, went to India, okay? And we sat down at a national stakeholders meeting with the government, the director of the National TB Program and his staff, the director of the Non-Communicable Disease Program looking after diabetes. Also key experts, all right, in your country who know about diabetes, know about TB, yeah? And then also some civil society, yeah? Very good. Good stakeholders meeting. To look at, say, look at the evidence. Is this a problem? Okay, we think it's a problem. Should we be screening? Yep, we should be screening. Okay. How are we going to do it? Because you've got to act. Okay, so we work out how we're going to do it. How are we going to monitor it? All right, because we need to collect data. Yeah? So we work out how we're going to monitor. And then finally, where are we going to do this? Yeah? So the national government says, I want you to do it here, 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 here. I want you to do it in hospitals. I want you to do it in health centers. Okay? Very good. And then, of course, the big chiefs say, when you've done this work, we want to know what's happening. So we have a national stakeholders meeting. Then we decide where we're going to do it. We need to train people in what to do. It's fairly straightforward, but we need to do a training. We need to teach them how to fill in registers. We then implement the screening, and we did it in both countries for just 9 months, all right? So we want to move quickly on this. We then bring everybody together, a little bit like all of you here. We brought everybody together, look at the data, let's put it together, what does it mean, and then we report back to the big chiefs, okay? So this period was done in both countries in about a year. A very, very good model. And because, of course, the national stakeholders say, this is what we want you to do, report back, they have a big interest in what's going to happen and whether they'll make a policy decision. So let me show you, let me tell you what happened then in India. So China decided on the same thing. So screening TB patients for diabetes, very simple. Nutsa, you're going to be my patient, all right? You come in, I'm going to ask you, Nutsa, do you have diabetes? And you will either answer yes or no. You probably won't answer don't know. Or if you say don't know, that means to me no, all right? So if you say no, or I don't know, I'm going to screen you, all right? So what I'm going to do is, because you're sitting in front of me, I'm going to take a blood test. It's called an RBG, a random blood glucose, okay? Now, I cannot diagnose you as having diabetes on a random blood glucose, but I can tell if you are a suspect. And what this means is that 6.1 means it's above a certain level. If it's above a certain level, Nutsa, I need to bring you back to do a fasting blood glucose. If you, Mukesh, were below, if your random blood glucose was 5.9, you're okay. You won't have diabetes. It's the way it works, all right? But above 6.1, I can't be sure. So then I bring you back, do a fasting blood glucose, and if your fasting blood glucose, Nutsa, is higher than 7, tough. You have diabetes. I've got to refer you to the diabetic clinic. Pretty straightforward. Everyone happy with that? Yeah? So, this is what we found in India. We worked in hospitals, health centers, so let me take you through this. We had 8,000 TB patients coming into the clinics, all right? So 682, 8% said, I have diabetes. Okay, you go, yeah. I have diabetes. So we know they've got diabetes, we just say, listen, you must make sure that you get proper care, all right? So that leaves us with 7,587 who need to be screened. So this is the reality of life. We should have screened them all, but we didn't. Some things go wrong. Nomaswazi, you might say, no, I don't want a blood test. It's your decision, yeah? I can't force you. Or something may have gone wrong, run out of needles or syringes. Anyway, whatever, 98% of people who should have had it done, all right? We then ended up with 2,838. This India uses milligrams per deciliter instead of millimoles, all right? So it's just a different threshold, okay? Anyway, 2,800 had a level that suggested they needed to have a fasting blood glucose done. Happy, everybody? Yeah? Shui? So I'm going to have to bring you back to the clinic, all right? Fasting, okay? So that wasn't too bad. So you can see that 2,703, 95% came back for a fasting blood glucose, of whom 402, 5%, had diabetes. Now, that's important. 5% of those patients did not have a clue they had diabetes. It's 1 in 20. Yeah? Quite a lot of people. So if you add all of this up, it basically translates to 13% of these TB patients had diabetes, and most of them were referred to care. You see, in the real world, it never works out 100%, 100%, 100%. Yeah? Amy, I refer you to diabetic care, and you decide, I don't want diabetic care. My human rights, grandma, my grandma can look after me, yeah? Grandma says, listen, darling, I know how to manage this disease, yeah? No Maswazi.
You said they can do the blood test, right? And then if it's above a certain
Yeah.
number, then you must come back.
That's right, that's right.
So if you then come back and you're not diagnosed, what does that mean? It's so suspicious.
Very good. No, very great question. Well, it depends. At the time you came to the clinic, you might have had a big meal that pushed your sugar up, and you didn't have enough time in your body to get that sugar, if you like, into your cells. You with me? Yeah. So it's a sort of, if you like, it's a screening test to say, Nomaswazi, you know, I don't know whether you had a big hamburger just before you came to the clinic, but we're just going to test you just in case. You with me? Yeah? Okay. Now, I just want to take you through India, because India really was fantastic here. So we presented these results to Sumitra. Who else is from India here? Mukesh gone, because I think he's meeting the minister. Anyway, we presented this to the national stakeholders, yeah? And the Indian government said, this is a serious problem. And a directive came out from the government to say, we're going to screen as a policy all TB patients for diabetes in India. That's a big policy decision. And we're going to provide glucometers, which are little machines, to do this. That's 2.2 million people, if it worked 100%, being screened every year for diabetes. So India prepared to make that resource allocation. Yeah? Similarly, India has to, this is the TB treatment card used in India. At the bottom here is the little bit about HIV, and India had to change all their treatment cards to add in about diabetes. I'm not going to go into great detail, but you know, there's quite a bit of work, this. Similarly, the register, they had to put another column in on the register so that people could indicate diabetic status. Because if you're going to do this, you need to collect information. Yeah? And then finally, need to decide, what are we going to report on? Now, you saw that big list of who's screened, who's got a random blood sugar. It's too complicated for programmatic use. So something very simple. So it was agreed that all we needed to do was every 3 months report on, in India, the number of TB patients registered. They do that anyway. The number who were screened for diabetes, okay, just to see whether the screening's working, and the number diagnosed with diabetes, period. All right? It's what they do in the HIV world, where they say basically who was tested, and WHO report on these figures this morning, for example. So globally, 48% of all TB patients in the world were HIV tested, and what were the results? Okay? So very simple parameters. Everyone happy with that, yeah? Good. Now, let's look at it the other way around. Everyone happy then screening TB patients for diabetes? Fairly straightforward. Interesting, that way, in China, we did this in China, presented to your national government. China not so convinced about rolling this out nationally. What they said in China, we'll keep this going, we'll expand to a few more sites, we'll make a national policy decision sometime. So not so convinced, yeah? Whereas India, I think, was more convinced, yeah? Now, this is more difficult. Well, it doesn't sound difficult, but it is. So here I have a diabetic clinic. Let's suppose you're all diabetics and you come to the diabetic clinic. What was decided that once every 3 months, because you probably come once every 3 months, yeah, I'm going to screen you for tuberculosis. The first question is going to be very simple. I'm going to say, Dawe, in the last 3 months since I last saw you, have you been diagnosed with TB anywhere else? All right? And your answer is probably going to be no. Okay? In which case, I'm going to ask you a few questions about tuberculosis. Yeah? What sort of questions do you think I should ask Dawe about TB? Cough? Yep. Cough for how long? 2 weeks? Yep. So you're coughing for 2 weeks? What else? Yeah, exactly. Dawe, have you lost weight? Yeah, very good. Yeah, what else? Night sweats? Very good. Oh, you're very good. We will roll you into the TB program after you've done this training. Night sweats and fever. Yeah, fever. So it's simple. 4 simple questions. Yeah, it doesn't take very long. Okay. And if you say yes, Dawe, to any of those, I'm going to refer you to be investigated for TB. Okay. So it sounds fairly easy. Now, we did this in India. I'm presenting Indian data, right, to be consistent. So let's look this through, because it didn't really work very well, as you can see. 12,000 diabetic patients screened for tuberculosis, all right? 74 said, in the last 3 months, I've been diagnosed with TB from somewhere else. So So a number of people being diagnosed with TB. Now that left about 12,000, whatever, 150 patients who should have been screened, and you can see that only half were actually screened. Yeah? It didn't work. Asking those 4 simple questions did not work in half of the patients. They weren't asked it, or it wasn't recorded. Okay? Of those people asked the questions, 135 said, yes, I have a cough, I have a fever, I have night sweats. 128 were referred for investigations, so some missed, and 11 were diagnosed with TB. So it's not a huge pickup, all right? We picked up 85 patients with tuberculosis, you with me, amongst 12,000 diabetic patients, giving you a case rate per 100,000 per quarter of 695. Now, this is where it all becomes a little bit, we're interested in TB, but actually it's a rarish disease, yeah? In India, which has a high burden of tuberculosis, the regular rate is 150 cases per 100,000 per year. That means 99,900 and whatever don't have any TB, and 150 do. It's not that common, actually. Problem is, if you don't treat it, if you don't diagnose it, treat it, it spreads, yeah? And then if you don't treat it properly, you get drug resistance, so you can then get, it's a big problem. But here, 695 per 100,000 is much higher than the background rate in India of 150 per 100,000. So to us, it seems this is a worthwhile thing doing, screening diabetic patients for tuberculosis. But we had some big problems. First of all, diabetic doctors not interested. This is too much extra work. I can't ask these 4 questions to you, Dawe. I don't want to do it. So, you know, very difficult to persuade them, all right? Also, no good recording system in diabetic clinics. We have a fabulous recording system in TB. Doesn't exist in the diabetic clinics. So what I would call no cohort analysis, no public health approach. So we ran into problems. So what's the way forward here? There's 3 important things. First of all, in a health facility, you've got to ensure that TB clinics and diabetic clinics are quite close to each other, or that they are integrated. Yeah. One of the problems. Who else is from China? Dawe and Zheng and Zizhen. Guo is easier. Yeah. So Guo. One of the problems in China. One of the problems in China was that I'd come to this hospital, okay, for my diabetes, and then the TB hospital is about 3 miles away. Yeah. So there was a geographical issue here, all right? So you've got to have these things quite close together, otherwise it's difficult for patients, all right? Secondly, our screening tools are not very good. So sputum smear microscopy is actually rather insensitive. Do you know what I mean by insensitive? It doesn't pick up all the cases. And people are now talking about Gene Expert. Have you heard about this machine, Gene Expert? Yeah. Gene Expert's better, but it's expensive, you know. Machine costs $10,000, $10 a test. Poor countries, you know, problem. Similarly with diabetes, the fasting blood glucose, my fasting blood glucose on you will miss, for some reason, it won't actually pick up diabetes always in you. It misses diabetes in sometimes nearly 50%. Yeah? So a much better way is to measure the amount of glucose in the hemoglobin. Hemoglobin is in the red blood cell, so called glycated hemoglobin. This machine costs also $2,000 US, $2,500 US. So it's expensive. So better screening, great, but you need the money for these machines. Yeah? And then finally, we need cohort analysis. Now, very quickly, I'll run through this quick, another 5-10 minutes, and then we'll have a discussion. Diabetes and TB treatment outcomes. If I'm diabetic and I have TB, I have a risk of having a delay in my sputum culture conversion, meaning it takes me longer to become non-infectious. All right? I have an increased risk of death. All right? And I have an increased risk that when I have completed my TB treatment, I'm going to get TB again. It's called recurrent tuberculosis. Now, these are, I'm going to just, I don't want, will you remember that, yeah? So this was to show you some of the studies, all right, where basically we're not totally convinced about the delay in sputum culture conversion, but we think, the evidence is building up to say we think this is correct. We're pretty convinced about death, all right? A risk 1.85, what that means is that if I'm a diabetic patient, I have an 85% greater chance of dying than somebody who does not have diabetes on TB treatment. Everyone with me? Carol, yeah, you and I have, I'm diabetic, you're not diabetic. Yeah, we both have TB. I'm 85% more likely to die on my TB treatment than you because of my diabetes. Okay? And similarly, with recurrent TB, I am 4 times more likely, if I'm diabetic, to get another attack of TB than you are. It's quite high. Why is there an increased risk of these adverse outcomes? We don't know, but possible reasons. First of all, the drugs from the diabetes world that I may be on interact with the TB drugs, and they're not good for each other. All right? So that's one thing. Secondly, if I'm diabetic, the TB drugs, which are already a little bit toxic for the liver, are even more toxic. All right? So there's a problem. I might run into some hepatitis. Thirdly, we've already seen if you're diabetic, your immunity's down. Yeah? And then finally, maybe coming to diabetic clinics regularly exposes me to TB. We're not sure. So there's many questions. I just throw this out to you. We really need some more evidence. We need to understand better that if I'm diabetic, can I improve my TB outcomes if my diabetes is better controlled? We don't know, right? Is 6 months treatment adequate? We don't know. Haven't done any studies on this. Maybe we should, if I'm diabetic, Carol, you're okay on 6 months, but maybe I should take 9 months. When do people die? It's important this, all right? If I'm diabetic, do I die at the beginning, in the middle, or at the end? Because that determines a little bit about interventions. Recurrent TB. Now, reactivation, reinfection, what this means, it's words we use in TB. If I have 6 months treatment and I do not get rid of those TB germs in me in that 6 months, those germs will multiply and give me TB again. It's called reactivation, right? Everyone happy with that, yeah? Now, Amy, you're South Africa, yeah? You have the highest rates of TB in the world, yeah? Where in South Africa do you live? Joburg. Okay, not so bad. If you go to Cape Town, that's the metropolis of TB, yeah? Where you run 1,000 per 100,000. So in Cape Town, you're likely to get reinfected, meaning if I'm treated, I can get rid of my TB. Great, I'm cured. And then I go and sit in one of your minibuses, yeah? All the windows shut, it's cold, 30 people, 2 people next to me coughing, 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 and I'm reinfected. Get TB again through reinfection, yeah? So we don't know in diabetes whether this recurrent TB is reactivation or reinfection. We need to know that because it's going to determine our strategies. Yeah.
You make the TB again. The normal one, or
it depends what you get. Normal Swazi, it depends what you get. So it's a very good question. If I can expand on that, because it relates to being drug resistant, yeah? New patients in the world with TB have a risk of drug resistance about 3%. If you've had TB before and you get it again, your risk of drug resistance is 20%. So two reasons. One is, if it comes back again, it may be that you haven't taken your treatment properly. You with me? And those germs have become resistant to the drugs. Yeah? But also it might be, you know, if you live in a high drug-resistant TB area like Eastern Europe, you're from Georgia?
Yes.
Georgia, okay. So Georgia's not so bad, but, you know, Belarus. Whew, Belarus, MDR TB, way up here, yeah? So I could have my TB get cured, and then I sit next to Nutza on the bus, and she's got drug-resistant TB. She gives me drug-resistant TB. Yeah? You understand? You haven't got TB, it's all right. Finally, this is the other challenge for care, preventing TB in diabetes. Now, because diabetes patients are at risk of TB, could we prevent it? And there's been 2 studies 50 years ago showing if you take something called isoniazid, it's one of the TB drugs, all right? If you take it for 6 to 9 months, you can get rid of these TB germs that live in your body, okay? So, quite good, but these were very bad studies. I hate to say it. They were done in Russia and in Germany. No one here from Russia and Germany, I hope. Yeah. So actually, one of the things I think we need to do, it's interesting, 3 years ago I'd have said, no, we don't need to do this. But I think, preventive therapy is going to be one of the keys to eliminating tuberculosis. And I think we need to look at this in diabetic patients. So I've changed my mind a bit on this. I think we're going to need to do properly controlled studies in diabetics versus non-diabetics to see if isoniazid preventive therapy can stop people getting tuberculosis. So that's the 3rd challenge for care. Now I'm going to wrap this up. I think very much diabetes TB is similar to HIV TB. Let's just look. Both of them increase the number of TB cases. Of course, HIV increases your individual chance much more, but there are 10 times more diabetic patients than HIV patients in the world, yeah? So this probably balances out. If you get TB with HIV or with diabetes, it's more difficult to diagnose. If your immunity is down, it makes TB more difficult to diagnose, yeah? And you can miss it. So, Nomaswazi, you may come to me, diabetic, all right? Pulmonary TB. I've had a cough that's come and gone, I've lost a little bit of weight. I do a chest x-ray on you, and I say, some changes. I don't think this looks like TB, but it could be. Because your weakened immunity is making the way your body reacts against TB different, yeah? There's an increased risk of death with both. There's an increased risk of recurrent TB with both. And there's an increased risk of treatment failure with both. So HIV TB is rather similar to diabetes TB. That's what I want to get. So this is my second last slide. If we're going to get a handle on tuberculosis, we've got to get, first of all, here a handle on HIV. Now, I think we're doing very well with HIV, actually. I worked in my last 6 years solely on HIV in Malawi with antiretroviral scale-up. And we've now got in Malawi about 550,000 people with HIV on antiretroviral treatment. And that scale-up in the last 6 years has altered the TB epidemic in the country. We used to get 28,000 cases a year. That number's come now down to below 20,000. Because HIV is a big driver of tuberculosis in Malawi. Robert, it'll be the same in Zimbabwe, yeah? Zimbabwe, Malawi, very similar. I know your people there very well, yeah? They're doing a great job. And similarly, your TB, I think, in Zimbabwe has come down in terms of absolute numbers, yeah? Yeah, from 2011 it started to come down. That's very good. So no doubt, if you get on top of HIV, we can get on top of TB. Now, the problem with diabetes is it's much more difficult to do. We've got to persuade people to eat healthily, yeah, not to go to the Kentucky Fried Chicken, the McDonald's, or whatever. But of course, I'm in a hurry, yeah. I need lunch. I'm starving. I love the chips they do. I love the Coca-Cola they give me. So it's difficult, yeah. And the food's cheap, yeah. That's a problem. But we've got to think of this. We've got to exercise. People don't exercise enough. My Indian colleague's not here, but I've been quite a lot to India. It's jolly difficult to exercise in India, actually. So I'm going to go and have a walk on the pavements in India. The pavements are broken, there's traffic everywhere. It's hazardous to walk, actually. probably be killed walking. so you've got to think, how am I going to make room to exercise? China's brilliant that way. Right? My experience in China was, we must learn, because the parks that I went to all set up for people of my age to exercise. Machines, all free of charge, and lots of people exercising. We need to learn lessons like this. Obesity, diabetes, clearly linked. All right, if you become obese, you will become diabetic, yeah, and vice versa, yeah. And then maybe early detection of impaired glucose tolerance. If I can pick if I can pick you up early with your diabetes, I can stop you getting complications and maybe stop you being at risk of TB. But I think it's jolly difficult, this, yeah? I'd be interested in your comments. So this is my last slide. So diabetes TB, there's a rapidly growing pandemic of diabetes. Okay, there's a big problem. This, I think, can threaten tuberculosis control. It's going to increase the number of cases if we don't get on top of it. It will increase the death rates and increase the risk of failure and relapse. And increasing failure and relapse will add to the cases. Yeah? So, you know, I wonder, I look at these global figures which have sort of come down and now are sort of plateauing off. And I see diabetes coming up. And I just wonder if diabetes is going to continue doing this, whether TB is going to start doing this. I don't know, all right? But part of me worries about this. And, you know, we're very ambitious in the TB world now. We're going to eliminate TB in 35 years' time. I won't be around, and you'll be around. Yeah, so I don't have to take responsibility. I should take responsibility. But it's a big job. Any of you know what eliminating TB means in numbers? Have people told you about the numbers? Can you remember the numbers? Dawi, can you remember? What?
10 years.
Yeah, not bad. It's less than 1 per million, Dawi, okay? That's elimination of TB, less than 1 case per million. At the moment, we are at 126 per 100,000, which means 1,260 per million. We've got to reduce in 35 years the TB load by 1,260 times. It's a big call, especially if TB incidence is now going to go up because of diabetes. You with me? So I think we've got to pay attention to this. Finally, we do have a global framework for these activities, but we definitely need more country-level action. China, great work. India, great work. But in other countries, in your countries, you need to bring this to the attention of people. Yeah? But actually, we should be starting to concentrate on diabetes TB, get some handle on what this issue is like. Now, there's nobody here from the South Pacific. I go and do operational research training in the South Pacific. They've got a terrible problem with diabetes in the South Pacific. Yeah, 40% of adults in the South Pacific are diabetic. Yeah, and why? No exercise, and they've stopped boiling food, and they now cook their food with oil. That's what people think. Yeah, so change in lifestyle, and it's caused them to have a problem. So I'm going to stop there. I'd be very happy to answer any questions, queries you have on diabetes TB. We're launching a report about this tomorrow at 10:45. To basically try and get people around the world up to date, knowledgeable about the seriousness of this issue. Yeah, yeah. Amy.
TB, diabetes necessarily, but there's been a huge surge in South Africa and popular media around low carbohydrate, high fat diets, and they've become extremely popular. And one of the reasons they always mention is that it will help manage your diabetes if you're already diabetic, and it will prevent diabetes if you're not diabetic. I just wanted to know what your views are on that word.
I'm not a dietetic specialist at all, but high fat strikes me as potentially dangerous. Yeah, it does. I mean, you know, it's not just carbohydrate that leads to this. You know, it's inappropriate fatty foods as well that can lead to this. So I don't know. To be honest, I don't know the evidence around that, but I would be a little bit worried about that. I mean, what sort of foods? I mean, can you give me an example of exactly what they?
So like you can have bacon and eggs and as much of it as you want for breakfast.
Yeah, no. Well, it sounds terrible. I'm at a hotel where I'm having bacon and eggs every morning since I've been here. That's definitely not good food for you, okay? It really isn't, because it, you know, that's A, going to clog your coronary arteries up, and B, if it makes you put on weight, obesity, diabetes clearly linked, yeah? That sort of thing would make you put on weight, to me, yes? And that puts you at risk of getting diabetes. So I'd be very wary of that, yes. Sounds nice, but...
Anybody else? Questions?
I just have one quick question.
Yeah.
All the research gaps that you pointed out, are there currently studies being done to find answers?
Yeah, no, it's quite good. I mean, a lot of people are beginning to get interested in this. So there's a lot of observational work being done on this. In Europe, anyway, I'm linked with a group at the London School of Hygiene and one of the Dutch universities that are looking at how best to screen, yeah, how best to treat, so looking at this whole clinical aspect, and then looking at what I call the biological science around the connection between diabetes and tuberculosis. Yeah, is it genetic? What is it that's causing diabetics to be at risk of TB? Is it this cell, that cell? Is it the fatty cells that they have? Yeah, the adipocytes, as they call them. So yeah, no, work's being done. Yeah, and it's nice to see this coming up actually. Yeah, at the moment we're still in the dark about quite a lot of the stuff, to be honest. Yeah, but maybe in 5 years' time we'll be better off. I mean, I think when we first started talking about this, Linda, 3 years ago, we didn't have as much knowledge as we have now. Yeah, so things are improving.
You mentioned, and other speakers have also mentioned how there needs to be that diabetic clinic and TB clinic should be
close together. Yeah.
So if they aren't, should they now
Yeah.
building more clinics, or how?
Well,
how would it
sure. Well, I think if one was serious about this, if one got serious about this, one needs to say, well, how, from a patient's point of view, does this work, this screening thing? I mean, at a peripheral health centre, it would be very good. It's very simple. Screening for diabetes requires a little machine take a blood sample, put it on a little dipstick, and put it in the machine. It's called a glucometer. Easy to train TB doctors to do that. Yeah. So I think it could easily be done to integrate this. Then, of course, it would be a question of, well, could they manage diabetes in a clinic? Well, I think the answer is yes. A lot of diabetic patients manage their own disease. So maybe you'd need initially to get some specialist help, but then I think you could be managed easily. Yeah? So I think it's political will about doing this, you know.
So you're saying it's not necessarily the infrastructure that needs to be like on the TB clinic?
No, that's right. But I don't know. I know in Malawi, for example, in the Ministry of Health, we now have a department for non-communicable diseases. Yeah? So looking very much, where can we treat chronic disease? So one of the health centres, it's quite a good model where they're looking after diabetic patients, patients with high blood pressure, patients with heart problems, patients with asthma. Yeah? So that's quite nice, and it's so in that same building they also look after people who are TB suspects, and they provide their TB treatment there. So you can bring it together. Okay?
Which would you say is more important, though, to integrate the diabetes screening and treatment or HIV with TB? Because obviously that's something else we've talked about is integrating
no,
that
absolutely.
and doing bi-directional screening with HIV.
Yeah. You know, I think, Linda, you have to look at the context. Africa, we have the big problem is HIV, TB. So the focus has got to be on HIV, TB. Go, however, to Southeast Asia and Western Pacific, not so much HIV, there's some, but not so much. Big problem there is diabetes. Yeah? So I think it's context specific, actually. South Africa, Amy, though, you have HIV, TB, and you have this growing burden of diabetes. You've got to pay attention to it all.
You've got great stories.
I have a small question.
Yeah.
You mentioned there are 11 million active TB patients
Yeah.
around the world.
Yeah,
And,
roughly.
Every year there will be 9 million more.
Yeah.
Will that be 20 million next year?
No, it doesn't work like that. So it's a very good question, Dawe. So how do you define a TB patient, all right? You basically define a TB patient from when you get symptoms, Dawe, to when you have completed treatment. With me? So generally speaking, people have symptoms for about 3 months before they get put on treatment. And then they have 6 months of treatment, or if it's retreatment, it may be a bit longer. So I'm a TB patient for 9 months or maybe 12 months. You with me? Or maybe a bit longer. If I'm MDR TB, I'm a TB patient for 2 years. As soon as I stop my TB treatment and I'm cured, I'm no longer a TB patient. You with me?
Someone died.
Absolutely, I die, exactly. But with diabetes, once diagnosed, it's cumulative. You're a diabetic patient for life. So it's a very good question, is how long are you called a patient for? Yeah? So generally a TB patient, I think generally WHO, if I remember, I think it says you're a TB patient on average for about 15 months. But this is including drug resistant, drug sensitive, you with me? So this is how they work out the prevalence, which is a bit higher of an incidence, yeah? Yeah.
Anything else? Okay. Well, thank you.
Pleasure.
Dr. Harris.
Okay, yeah, pleasure.